This is Dr. Chaudhary. I will be talking about the workup for hematuria. Hematuria is defined as the presence of blood in the urine, and on urinalysis is greater than 3 red blood cells per high-powered field. This can be microscopic or gross. Microscopic hematuria cannot be seen with the naked eye, and on urinalysis is greater than 3 RBCs per high-powered field. Gross hematuria is visible, and all patients with gross hematuria should undergo a full workup. Having red urine does not always indicate the presence of blood. There are several drugs that can cause a reddish tint to urine. Certain medical conditions such as myoglobinuria or porphyria can cause urine to be a dark red color. This is due to breakdown products of hemoglobin in the urine. There are several etiologies of hematuria. The source of blood can originate from the kidneys, ureters, bladder, prostates in men, and urethra, essentially anywhere along the genitourinary tract. The following acronym PP on this can help with remembering common etiologies for hematuria. A full workup helps us determine the etiology, especially if it is a tumor. The diagnosis of gross hematuria is easy, since blood is visible in the urine. However, a urinalysis still should be performed to confirm the presence of blood cells in the urine. Remember, there are some drugs and conditions that discolor the urine. A urinalysis is the mainstay for initial diagnosis of hematuria. A positive result is greater than 3 red blood cells per high-powered field. The urine sample must be clean catch midstream voided specimen or a catheterized specimen. First morning void is ideal as urine is less hypotonic and the RBCs are less likely to undergo lysis. A dipstick is applied to the urine and the dipstick will change a certain color depending on the amount of RBCs. This gives a qualitative measurement of the estimated amount of RBCs, but a microscopic analysis of the urine must be performed to accurately count the number of red blood cells per high-powered field. False positives include myoglobinuria, hemoglobinuria, and iodine contamination. False negatives include excessive vitamin C intake. If RBC cast or dysmorphic RBCs are seen under the microscope, that would indicate an intrinsic renal etiology. If a patient has gross hematuria confirmed with urinalysis, then there is a 23% chance of finding a urologic malignancy on initial workup. In about 8% of patients, no etiology is found. If a patient has microscopic hematuria, then there is a 1 to 5% chance of finding cancer on initial workup. Given these numbers, a patient with gross hematuria should always undergo a full workup. But a person with microscopic hematuria does not necessarily need a workup unless they have certain risk factors. Most often, we don't find the etiology of microscopic hematuria. A full urologic workup is indicated in a patient with microscopic hematuria if A. They have greater than 3 red blood cells per high-powered field on 2 out of 3 consecutive urinalyses, or B. Greater than 3 red blood cells per high-powered field on 1 urine specimen and the following risk factors: smoking history, occupational exposure to chemical dyes such as benzenes or aromatic amines, a prior history of gross hematuria, age greater than 40 years, a history of urologic disorder or disease, a history of irritative voiding symptoms such as pain with urination, urgency, or incontinence, a history of urinary tract infections, long-standing analgesic use, or pelvic radiation. A full urologic workup for hematuria includes a complete history and physical, urinalysis and urine culture, urine cytology, upper tract imaging, and cystoscopy. Upper tract imaging can include a CT urogram, an intravenous pyelogram plus a renal ultrasound, or MR urography. Hypertension, renal insufficiency, significant proteinuria, RBC casts, or dysmorphic RBCs on urinalysis are signs of renal parenchymal disease. Nephrology should be consulted if a patient has any of these signs. Urine cytology detects abnormal exfoliated urothelial cells in voided urine. If cells are malignant or atypical appearing, then further cystoscopy and upper tract imaging is recommended to determine if a tumor is present in the bladder, ureter, or renal pelvis. The sensitivity of this test increases with higher grade of disease. Urine cytology has higher specificity but lower sensitivity than other urothelial tumor markers, especially with low-grade tumors. Despite this, it is still considered an integral part of the urologic workup. The point of upper tract imaging is to identify any tumors, lesions, or stones. Upper tract imaging includes an intravenous pyelogram plus renal ultrasound, or a CT urogram without and with contrast, or an MR urography. CT urogram is the gold standard and most widely used imaging modality. The study is done without and with contrast. After contrast is administered, imagers are taken at two phases, a nephrogenic phase and an excretory phase. The excretory phase is crucial and will identify any lesions in the renal pelvis, ureter, or bladder as filling defects. Intravenous pyelogram plus renal ultrasound are not as sensitive and only offered if CT is contraindicated or not available. MR urography is very expensive and usually reserved for those with iodine allergies. Cystoscopy is a procedure of looking inside the bladder with an endoscope. It can be performed in clinic or in the operating room. It is invasive, but low risk and very quick. Cystoscopy will identify any suspicious lesions in the bladder. These lesions are usually inflamed, pedunculated, or velvety. If suspicious lesions are seen in office cystoscopy, then the patient will need to be taken to the OR for biopsy and transurethral resection. If in the operating room, the patient may undergo retrograde pyelograms to evaluate filling defects in the ureters or renal pelvis. This can be done if the patient did not undergo a CT urogram prior to biopsy. In conclusion, all patients with gross hematuria need a full urologic workup. Patients with microscopic hematuria need a workup if certain risk factors are present. Urine cytology is specific and sensitive for high-grade lesions, but not low-grade lesions. CT urogram is the preferred imaging modality to look for tumors or stones in the upper tracts or kidney. Cystoscopy is the best way to identify any lesions in the bladder, and all suspicious lesions should be considered for biopsy. I do hope that this lecture has provided you with a comprehensive and systematic way of approaching a patient with hematuria. Thank you.